When the macular hole had a diameter of less than 250 microns, which is here, then you see that the success rate was over 50%, was almost 60%. So when you have very small holes, it works very well. Once the diameter goes above 250 but below 400, then we have around 40% success rate. When the hole is larger, we don't really expect for the drug to work. So it's really for holes less than 400 microns and even better for holes less than 250 microns. The visual acuity improved in 25% of cases by 3 lines, and that goes along with the resolution of the adhesion and the closure of the macular hole in the MIVI trials. In 2015 in ARVO, about a month ago, we had some interim results of 2 large studies that have already started, but are going to finish in 1 or 2 years' time. We have some results to give an idea of how those studies are going, and one of them was the OVID trial, which is a prospective multi-center single-dose Ocriplasmin trial of 400 patients that looks into the anatomic and functional results, has a 6-month follow-up, and it has a very strict indication, which means that in order for a patient to get into the trial, the OCT of that patient pre-surgery has to go into a reading center, has to be evaluated, and if it fits the indications, then goes back and gets into the trial. And all the OCTs throughout the trial goes through the reading center, so it has very strict indications, and it's kind of like in laboratory conditions. And the first results are expecting to come out in 2016. In ARVO, that the researchers gave interim results of 200 patients. They showed that the rate of resolution was 37% in the first week and almost 43% in the first month of resolution by using Ocriplasmin. The other study that was used was they showed some interim results was the INJECT study, which is also an Ocriplasmin trial of 1,500 patients that looks into the anatomic and functional results in real-world conditions this time. It's not so trial-based setting, but it's in real-world conditions. Has a 12-month follow-up, and the entrance of the patients into the study, it's at the doctor's discretion, and also the doctor decides which 4 visits of the patient is going to be to include in the study. So it's more relaxed. It's more along the everyday use of the drug. And the first results are expected in 2017. But the interim results came from 94 patients so far. That's how many have been recruited. And it shows in all patients a 30% resolution rate with Ocriplasmin. In patients that had a focal adhesion less than 1500 was 32%, where in patients with broader adhesion was 0. No one had a resolution. And in patients that had ERM present also there was 0 success rate, where in patients that didn't have an ERM was a 39% success rate. Those are the results from 94 patients of this study. There were also other studies in ARVO 2015 looking at Ocriplasmin. One of them was ORBIT, that there were some data announced in ARVO. That was an Ocriplasmin trial of 1,500 patients from 120 centers that looks into the anatomic and functional results in real-world conditions as well, has a 12-month follow-up, and the visits are at doctor's discretion. And at ARVO, the researchers presented the demographic and entrance data of that study. And there was the Ozone study, also a study of 200 patients from 30 centers that looks into the anatomic and symptomatic changes from OCT. You have to remember that OCT was not included in the pre-approval studies of Ocriplasmin. So after the Ocriplasmin was approved, there are many studies that looked into the OCT and its changes after the use of the drug. So that looks at the OCT changes, has a 6-month follow-up, and it's trying to detect patients, the photoreceptor changes on OCT up to day 21 of those patients by using the Ocriplasmin. This study also, the research presented the demographic and entrance data of that study. There were other studies as well that were presented in ARVO. One of them was comparing gas with Ocriplasmin and vitrectomy for epiretinal vein removal. And they say that the researchers say that vitrectomy is the procedure of choice, but from the other two, gas might work as well as ocriplasmin for the removal of the periretinal membrane. Another study was comparing observation with ocriplasmin and vitrectomy for vitreomacular traction, and they say that after vitrectomy, which is the procedure of choice, maybe observation may have the same results as ocriplasmin by into the follow-up of patients with VMT. There was a study that studied the mid-periphery with OCT after the use of ocriplasmin, and they tried to see what happens in the mid-periphery when the drug works on the macula. And they saw that in some patients that the drug, by using the drug, the patients had resolution of the adhesion at the macula. There was not PVD on the mid-periphery. So the use of drug might mean resolution of the traction on the fovea, but it doesn't necessarily mean that a whole PVD, complete PVD, happens in the eye. 3 more studies of ocriplasmin efficacy were presented, where 54, almost 55% resolution rate was found, and 45% of hole closure also was found in those eyes. To give an idea of how hot the subject is, in Retina in June 2015, there was an editorial, there was another paper, there were more papers, there were in total 7 papers regarding ocriplasmin. So there is a lot of research going on at the moment about ocriplasmin, and I'm sure that you're going to see more in the future about this treatment. So those are the good results, but sometimes there are clouds in the horizon, and those are the side effects. As you know, everything we do in medicine doesn't benefit the patient also only, but may have side effects. From the MIVI trials, the trials that were done before the approval of the drug, we know that the first week we may have some side effects, and those are mainly vitreous floaters, reduced visual acuity, retinal macular edema, which mainly are related to the action of the drug, which is the induction of PVD and the separation of the vitreous from the retina. When we looked at those side effects after the first week, up to the month 6, we saw that those subsided, and they went almost at the same level where the placebo group was. So it's obvious that those were mainly from the induction of PVD and not from the drug itself. But after the approval of the drug, we had many researchers that tried to see whether the side effects that were found before the approval of the drug were the same after the use of the drug, after the approval, by using the drug in the real world. So there was a paper published in Retina 2015 that looked at the pre-marketing side effect compared to the post-marketing side effects. They looked at all those categories of side effects to see whether the data before approval are consistent with the data after approval. And actually they saw that they are. And actually, as you can see on the right column, the percentages are lower after the post-marketing use of the drug than it was pre-marketing. So they had fewer side effects of the use of the drug in real-time worlds. Of course, you have to, what it says, ellipsoid zone findings, you see not applicable before, because as I said, in those trials, the OCT was not studied with ocriplasmin, so we have findings only on the post-marketing use of the study. But you have to take those results with a pinch of salt, because on the pre-marketing trials, all side effects had to be reported. On the real-world study, not all researchers report the side effects, so that might be an underestimate, and the side effects rate might be higher than what it is presented here. Of course, you should know that the drug induces some tractional changes on the macula, and therefore it should be used carefully in eyes with many retinal holes, with significant lattice, or high myopes with thin retinas. In AVO 2014, there were data presented from almost 11,000 patients, and again we saw that the main complaint was the visual impairment in 2%, and the rest were about 0.5% of dyschromatopsia, retinal or macular edema, macular hole development, or retinal detachment and tear development, which are consistent with the use of the drug and its action on the vitreous and the retina. There were some reports concerning the ERG changes, which was 0.08%. You see that the percentages are very low. That was 9 patients overall. 7 were considered serious, and 3 of them resolved only. And its cause was considered to be either mechanical or biochemical action of the drug on the photoreceptors and the RPE. Papillary defects were presented in 25 patients, 19 of them considered serious, and 12 resolved of those, and the causes were again mechanical or biochemical action on photoreceptors and the RPE. Vascular changes were presented in 8 patients, 6 of them were considered serious, and 2 of them resolved. OCT changes, as we know, were studied after the use of the drug. In 47 patients, 14 of them were resolved. Lens subluxation, which was something that we're expecting because the drug acts on the collagen, and they were expecting that there might be some problem with the zonules. But however, the lens subluxation was very low, was 0.065%. Only 9 patients presented as lens subluxation. And the cause, of course, is a biochemical action on the drug directly on the zonules. And subretinal fluid was presented in quite a few cases. The rate ranged from 40 to 70%, with a resolution rate of 40%. That was presented quite commonly. In AVO 2015, we had, that's a month ago, we had some new results. We had results from the OVID study, which had a rate of side effects of 1.6%. Again, you see the percentages are low, quite low. VA reduction of 0.6%, macular hole 0.6%, detachment 0.3%, and zonules dehiscence at 0.3%. The INJECT study showed a few more side effects. VA loss at 2%, reduction at 0.7%, macular hole 6%, and retinal detachment almost 3%, has a higher percentage. One study compared a group with a normally occurring PVD with a group of patients that had Ocriplasmin and studied those with OCT. And they noticed that at the eyes with normally occurring PVD, they didn't find the changes on OCT that were found on the studies that Ocriplasmin was used. And they were wondering whether the changes that we see after the use of Ocriplasmin are not due to the induction of PVD, but actually may be due to the drug itself. One study showed a 33% reduction in ERG and photoreceptor changes after Ocriplasmin. Of course, there is a subject of the cost. There was a study done in 2014 which compared with the Markov model three scenarios. One was a vitrectomy as a primary procedure, one was Ocriplasmin as a primary procedure, and intravitreal saline injection as a primary procedure. And here you have to know that when the studies were done with Ocriplasmin, the sham group was not a group that were just pinching the conjunctiva. They were actually injecting saline into the eye. So they were really comparable, those two groups. So they studied the cost of those procedures, and they found that vitrectomy and intravitreal saline injection had approximately the same cost, where Ocriplasmin was more expensive by approximately $3,000. So Ocriplasmin is a new drug and is a new treatment modality, which is here apparently to help us, is a new weapon we have in our armamentarium to treat vitreomacular attraction and full-thickness macular hole. It provides an alternative treatment without surgery for a small proportion of patients with traction and macular hole when those are indicated, and I told you the indications before. It is early, because it's been only 2 years that it has been used. It is early to draw any definitive conclusion regarding its safety. We have to do more studies to see how safe it is and when it is best to be used. Still, vitrectomy at the moment remains the procedure of choice for patients with vitreomacular attraction and macular hole, but it seems that in the future it is very likely that we will see an expansion of its use in the future. For example, it's already been tried in age-related macular degeneration. In ROP is going to be tried. In diabetic macular edema, where traction plays a role, and you know that vitrectomy, when there is a taut posterior hyaloid, is a procedure of choice. In optic dyspepsia, there are diseases that traction plays an important role, and there Ocriplasmin may come in quite handy. I would like to thank you all very much for your attention. Any questions? Thanas is not here to take the chair, so yeah.
I was wondering, because on the slide of the costs with the Markov model, the saline injection was more expensive than the vitrectomy.
Yeah.
How is that possible?
Okay, well, that's a few dollars, not much more, much more expensive. But
Yeah.
that's how it works. You have to remember those Markov models it takes everything into consideration. It takes the visit it takes the cost of surgery. It takes the cost of the surgeon. It takes the cost of the whole hospital. It takes the visit of the patient to the doctor. It takes the visit of the people who go with the patient to the doctor. Take the leave that they take on their job, the OCT that they make. Also the procedures after that, which means that if a saline injection doesn't work, then they will have to have a vitrectomy. That's included. And that vitrectomy may cause in a phakic patient, may cause cataract. That's included too. So you have to take the whole trail of the procedure. That's why they are so expensive. It's not just one injection. It's the whole procedure to the end. So that's why it might make vitrectomy works better if it's a first choice procedure. That's why. Nothing more? Okay. So shall we proceed to the next speaker?